and welcome to this webinar brought to you by ICU Reach. Tonight, our webinar is about the management of pulmonary embolism, and we have a panel of experts in the field. So I will pass over firstly to Talal Dahan, who is one of our experts, and he is an assistant professor of medicine at Duke University and the Critical Care Fellowship Programme Director. Thank you very much.
Thank you all for being here. It's great to discuss pulmonary embolism at any forum, really, but more wonderful to have great two experts and mentors of mine weighing in for us on management of a common disease, but really can be tricky if we don't really try to be careful in assessment. Please allow me to introduce Dr. Nabil Abu Shala, who's one of my dearest friends and mentors in the field of pulmonary medicine and critical care as well. He's probably the one who embedded loving pulmonary embolism in me to begin with for management of patients and what we should do. Dr. Abu Shala is a senior attending and expert in the field. He currently practices critical care medicine in University of North Dakota in Fargo, as well as pulmonary medicine in University of Alabama, Birmingham. Also allow me to introduce another dear mentor and friend, Dr. Victor Test, who I happened to meet when we were lucky at Duke to have him as the director of our Pulmonary Vascular Disease Center a few years ago. And he decided to go back to his hometown, Texas, as a division chief of pulmonary medicine and critical care in Texas Tech. Professor Test is well known in the American College of Chest Physicians, and we are looking forward to hearing from him about his experience and input on management of pulmonary embolism. Without further ado, I'm going to pass the mic and the slides to Dr. Abu Shala for updating all of us on the recent evidence that we may have come across or not, and elaborating on how we approach pulmonary embolism. And then I am going to present three interesting cases, if I may say, on approaching how we should manage them and have input from you all. So be ready with your answers on the poll questions when they arise on Zoom as we direct the case. Dr. Abu Shala, the mic is yours.
Thank you, Talal. I'm really honored to be here today and to join this group today. It is a very dear topic for me to talk about pulmonary embolism. It's one of those controversial issues that we want to discuss today. It was really hard to choose what part to present today. So I'm going to look at it from an aspect mainly as an intensivist, seeing these patients ending in the ICU in various presentations. And I want to say, no matter how much we learn about pulmonary embolism, I think each one of us probably has missed one or had difficulty in making decision. And I think as we will talk later, the multidisciplinary approach is probably the best in difficult situations. So with this, my plan is to touch some controversial points and maybe some updated literature. And I will try to be brief because I like to spend more time, dissecting the cases that Talal will be presenting later. And certainly look forward to hearing Dr. Test commenting about the management and anything that I present today. So, these are the big questions that we all face. Should we give these patients thrombolytics or no thrombolytics? And sometime when we do that, how do we do it? Do it systemically, like a regular peripheral infusion, or do catheter directed? There's a lot of literature and talk about this, but we're still waiting for randomized trials to give us some definitive answers. And how much should you give a thrombolytic if you decide to give it? So that would be sort of the plan. And I will initially, as a lot of you have faced the spectrum of pulmonary embolism, but these are sort of the various manifestations. And I really spent quite a bit of time to find out the incidence of these various forms from what's called massive PE, catastrophic PE, submassive PE, and PE that is none of those categories, so we call it normal blood pressure and RV function. And these are the sort of the best numbers. And you can see a large number of variation from what is called massive PE, the one associated with shock state, somewhere between 2 to 5%. And catastrophic PE, the one that usually present with cardiac arrest. And then I've seen literature up to 30%. I doubt this number is accurate today, maybe. And then I've seen less than 1%. And again, I don't have a good answer. These are the variations that I've seen. Now, submassive PE, you look a lot of the analysis of large collection of registrations for pulmonary embolism. And again, I see variation somewhere 2 to 25%, probably closer to 20%. And these are the patients that there is a lot of controversy how to manage them. The normotensive with RV dysfunction and have higher risk of adverse outcome. And then the normal PE, those that we diagnose many times incidentally, or sometimes the patients will have symptoms coming to the emergency room, they're stable. And now a lot of the guidelines recommend that we start these patients on anticoagulation, discharge them home. So this is, again, maybe 75 to 95% of the population. So when we want to stratify the patients, I think there's various parameters have been talked about, from clinical evaluation, looking at the appearance of the patients and the vital signs, the assessment of the RV dysfunction, either clinical, like distended veins and tricuspid regurg and P2, from the EKG changes, which are, again, not very common when they're present. They usually give a prognostic assessment that there is an RV dysfunction or strain pattern. And then the cardiac parameters have been quite important in regarding risk assessment. RV dysfunction and the echo is one of the probably the best way to assess if it is present or not absent and how severe. And then on the CT scan, you'll see a lot of literature talking about what's called the RV-LV ratio. And when the right ventricle enlarges in size because of the pressure, that is pretends that the patients have RV dysfunction. So it is an indirect sign. The echo, I believe, is more accurate. But I like to point out that there is a recent paper in 2022. It's a very simple marker, and I like simple things, particularly for those of us, when we see patients at the ER, which is really simple, as simple as a heart rate. This is it. Before we go to the heart rate, here I'm mentioning what the European Society of Cardiology defined what is shock, and this is from their guidelines. So shock, in their definition, either obstructive shock, certainly if you have CPR, or if you have a hypotension and an organ hypoperfusion, or if you have a persistent hypertension or a drop more than 40. So some of the cases we can hear from Talal, we want to look at, do they, what category these patients would fit in, as far as do they fit the definition of what's called hemodynamic instability. So the heart rate has been looked at in this paper published in CHEST 2022 that looked at the prognostication in acute PE. And looking at short-term mortality, the number is really quite large, 44,000 patients that presented with symptomatic pulmonary embolism, and the outcome. And I feel like this graph can say it all. If you look, this is correlation. It seems to have a nice linear relationship between the heart rate and the 30-day mortality. And I think that sort of cutoff around 110 can help, any physician who sees patients with acute PE. Do I need to worry about this patient? This is without checking any parameters. There seems to be a very good correlation. And then when they looked at 30-day outcome, there's many parameters that shows as you increase the heart rate. I find it also very helpful if you start therapy, particularly anticoagulation, your patient's heart rate increases, or you give thrombolytic and the patient's heart rate did not decrease or continue to be high, there's no other explanation, then I think you need to worry about those patients. Now, what is submassive pulmonary embolus? I think that's a term that's been, used very frequently, and that's where I believe we're going to discuss most of the cases in this category, where there's a debate about how to manage. It's been defined in this article in circulation about patient having elevated, cardiac markers, BNP, cardiac troponin, evidence on echocardiography of having increased RV to LV ratio and RV dysfunction, and the CT scan showing the same. And then EKG changes, as we see here. Occasionally, you can have similar finding to a STEMI from patients that are having RV strain pattern. So this is what has been discussed, but as you can see here, patients should have normal blood pressure or the systolic blood pressure more than 90. That's sort of the agreed definition of this type of category in submassive PE. So if we look here, and I know that looks like a busy slide, but I will simplify it here. We have shock and hypotension, RV dysfunction, and evidence of myocardial injury. If you have all of these, and most patients who are in shock do have RV dysfunction and have evidence of elevated troponin and BNP. So these are the patients that classically we give thrombolytics unless you have a contraindication. And then the low category is when you have none of these features. So those patients, we don't give thrombolytics, we just anticoagulate the absence. And then depending on how much of these you have, so if you don't have shock, and you have evidence of RV dysfunction, and you have evidence of myocardial injury, then you have a submassive PE, and that's where the debate is. And then there is a definition where it's called low risk, intermediate, high risk. And I think if you have those two things, which is RV dysfunction, evidence of myocardial injury, becomes a high risk submassive PE. So with this, I believe that the PERT trial addressed this question is how should we treat these patients? And now we'll only touch base because I feel like that's a critical trial. Then we're looking for those, I think they're called the high PETHO, which is a follow-up for that study. So this study really showed that if you have a PE and you have normal high pressure and you have RV dysfunction and you have evidence of myocardial injury, that was a randomized controlled trial of using systemic thrombolytics. The trial showed overall, if you look at all sort of combination of outcome, mortality, hemodynamic collapse, progression, that patients will have lower the composite outcome. So and with a significant p-value. But the problem was, the second part was that there was a significantly more hemorrhage, about 10-fold increase in the incidence of intracranial hemorrhage and hemorrhagic complications. So that's really what prevented us. So yes, you are gaining benefits in the outcome of the patients when you do look at the composite, but the incidence of bleeding, and that what made the conclusion from this study is that do not recommend systemic thrombolytic therapy as a trial did for patients with submassive PE based on these categories. So I think it left us a sort of and what to do on such patients. And then there are some smaller studies about using lower doses of thrombolytic. The traditional dose that has been recommended based on prior STEMI trials is using 100 milligrams over 2 hours. As I think if you look, there are some smaller papers. This is looking using IV infusion with lower dose again, and then the other one was a CDT trial. So this is from the Moffitt. So both of these trials show that if you use lower dose of thrombolytic, you have the same effectiveness. So half the dose, similar efficacy, and significantly less bleeding. So maybe lower dose is the one that we've used before. We should not use anymore the 100 milligram dose of TPA. But again, I don't think we have enough data yet or large numbers to make that recommendation. So currently, what I've seen in the literature is the regular dose, the previous dose is 100, the low dose is 50 milligrams, and then there's an ultra low dose, which is about 1 milligram per kg, or I'm sorry, half a milligram per kg, or sometimes 25 milligram, but instead of giving it over 2 hours, you give it over 24. So it's the infusion. And that is very comparable to what the catheter-directed therapy uses most of the time. They use 0.5 to 1 milligram per hour for 24 hours. So maybe this data will tell us that we can do thrombolytics and in a much safer way and less incidence of complications, particularly bleeding and intracranial hemorrhage. So with this, I wanted to mention that the catheter-directed trials have been many, but really not randomized control trials to give us an outcome measure. This is the one of the initial papers in 2013, and I know there's quite a few that have been published in the past 10 years, and I believe there are some randomized, but we're still waiting on definitive answer in this aspect. So what the guidelines say, and these are the most recent guidelines, and glad that Dr. Tess is with us today. I'm sure he contributed to the ACCP. But I wanted to mention here in general with the guidelines, and this I've taken this from the European Society of Cardiology. If you have a low-risk patients, meaning that you have normal blood pressure, as I mentioned, no biomarker, no RV strain, no EKG changes, these patients anticoagulation only. The high-risk patient, you give these patients with the massive category. These patients would get what we call primary reperfusion therapy, which is the systemic thrombolytic. And I think that yet we don't have a recommendation on lower dosage. The intermediate risk, currently the guidelines say don't give anything, just give anticoagulation. If your patients deteriorate on anticoagulation, they consider what's called rescue reperfusion therapy. And there's no clear answer. I think the ACCP still favor thrombolytics systemically. I don't see any guideline recommending catheter-directed therapy, but I know in reality, a lot of us are preferring the catheter-directed therapy because of the lower dosage. So with this, I think you've heard a lot about the PERT team, but this is the team where you have a multidisciplinary approach. Probably Dr. DeHaan will speak about this in his presentation about how the PERT team at Duke University and maybe other centers contribute to help people make some of these difficult decisions. So with this, I will stop and hand it to Dr. DeHaan.
Thank you, Dr. Abushala, for a brief but rather important update on management of pulmonary embolism and how we approach taking care of these patients. In order to allow us understand things better, I think it is better to go through cases, and this way we try to illustrate what was missing and answer a few questions that may come to mind. Before I start the first case, Dr. Tess, do you have any comments or thoughts, or you would like to comment after the cases?
Well, I think that was a very nice summary of where we are with management of pulmonary embolism. I think as we go forward, I think the first thing to remember is that anticoagulation works. It works for the majority of patients. I was really thrilled that we referenced the PETHOS data. And I think one of the things about that data that's really important that is that in the people who were randomized, or what drove the positive trial was crossover from the standard care group anticoagulation to thrombolysis. And that was based on the clinical impression of the attending physician. And if you look at that, there was no difference in mortality with that group. But if you also take that subgroup of people who crossed over, there was no penalty for treating the patient with anticoagulation and then crossing over. They did, in other words, waiting to give thrombolysis in that subset of people that crossed over. Those patients didn't have an increased mortality. And that's something that sometimes is lost in the woods of that rather impressive study. We can talk more about catheter-directed therapy and other interventions here in a moment, certainly in the evaluation of the guidelines.
Thank you, Dr. Test. Let me start with the first case, just see what people think. This is a 58-year-old male who has a history of hypertension, hyperlipidemia, developed over 2 days, sudden onset of shortness of breath. And remarkable in his history, when you dig over things, that he had 9-hour travel between 2 states when he presented to the emergency department with this. His blood pressure was 132/78, heart rate of 85 beats per minute. His oxygen saturation was 95% on room air. He had a clear chest exam and remarkable cardiovascular exam, and he had palpable peripheral pulses, warm extremities. Everything looked stable clinically. Had unremarkable basic labs, and then to investigate further, he underwent this CT scan of the chest that I'm going to scroll over for you all and try to elaborate on findings. So his CT showed, as you scroll down, this is the thoracic arch of the aorta, and then as it splits for us to understand reading, and I'm not a chest radiologist, but you can see that the main trunk of the pulmonary artery with bilateral main pulmonary emboli are shown there with filling defects. They are, for the most, acute. None of them have chronicity features. And then as you go down, and this is where Dr. Abu Shala was mentioning how we look at the RV to LV ratio. You try to find a cut on the CT scan that has no vessels coming out, and then you try to look at 1 centimeter below the annulus, the RV to LV ratio, and it looks reasonably preserved here without really signs or concerns of RV dysfunction. So RV looks normal. Patient has what was thought to be significant clot burden, pulmonary emboli on both main pulmonary artery branches. Occasionally, we look at the main pulmonary artery diameter in relation to the ascending aorta, and the ascending aorta here looks also normally larger in size than the main PA. Then as you try to go down, nothing really shows on other image. I'm gonna scroll one more time for everybody just to appreciate the findings. So as we go down the thoracic arch of the aorta, you see the filling defect on the left main pulmonary artery, and then the right main pulmonary branch as well. The main PA trunk is looking great. And then as we go down to assess the right ventricular size, it is normal in size. Right atrial size is also looking okay. Left ventricular size is fine. So with that CT scan in mind, this is the echocardiogram for the patient. This is an apical 4-chamber view that shows us the 4 main chambers of the heart. This is the right atrium. This is the right ventricle, the left ventricle, and left atrium. Left atrium is normal in size, so as the right atrium. And typically, and I'm a pulmonologist, I'm not a cardiologist, but what we look at on the echocardiogram, we try to see, is the apex predominated by the LV as we normally have, or the right ventricle? And here it is nicely predominated by the left ventricle. You want the size of the right ventricle to be within 2/3 of the left ventricle, and it is the case. It's not equal in size, it's not larger. So we have a reasonably unremarkable looking apical 4-chamber view of the heart. With the CT scan we mentioned and the echocardiogram finding, now we are going to open the floor for your contribution and tell us, what do you want to do for this patient? So would you want to observe for 12 to 24 hours and do nothing? 2, you want to admit the patient to the hospital and start anticoagulation. Or you want to admit the patient to the ICU and start enoxaparin. Maybe discharge the patient home after prescribing anticoagulants, or transfer the patient to another hospital and go from there. So if we want to raise the poll questions, Grace, and I will allow 30 seconds to 1 minute for all of us trying to think what we should do for this patient. Just remind my colleagues and friends that hosts and panelists are not allowed to vote because we probably know the answer.
I see the results going to be very interesting. Alon,
This is why we're doing
Victor
this
and
session.
Nabil.
15 more seconds, and then we'll look at the answers. All right. Okay, so observe for 12 hours, appropriately did not have a lot of responses. Admission to the hospital and start IV anticoagulation with heparin infusion. Some people thought that this deserves an ICU observation. Discharging the patient to home after prescribing anticoagulants was only 15%. Transferred the patient to another hospital. It was not thought to be necessary. What do we think? Let me start with Dr. Test. What are your thoughts on this case and where we go from here?
You're muted, Victor.
Yeah. So I think the only one that's clearly I think problematic is to observe for 12 hours. And every piece in the every other part of the answers that were received involved anticoagulation. The most important thing in improving mortality and pulmonary embolism, particularly in what are considered low risk pulmonary embolism, is prompt therapeutic anticoagulation. The guidelines, the ACCP guidelines, would suggest that this patient could be safely treated with direct oral anticoagulants and discharged to home. And I think that's true. Now, that a lot depends on the availability of direct oral anticoagulants that you have. It also depends on the reliability of the patient. Depends on their social support. So it's a complicated question, but I do think whatever you choose, you choose prompt, aggressive, upfront anticoagulation. Dr. Abushalem?
Well, I can't add much more to that. I would agree. I think it's initiating anticoagulation, and I feel based on all the criteria we discussed, I don't see any increased risk for this patient to warrant admission to the hospital. I know I'm maybe from the old school that I could not believe initially that a PE patient can go home. And we've always used before heparin, bridge with Coumadin, wait for about a week and measure the INR and so forth. But now we have so many newer anticoagulant that would become effective immediately. And I think this option is available for the patients, particularly with either enoxaparin or some of the DOACs. And I think that would be pretty safe for these patients and spare them admission to the hospital.
So just for the sake of discussion, and since I have great experts with me here, shouldn't really worry about the size of the clots, and they're big and huge and proximal. Why shouldn't we consider something else to be done? Dr. Test.
Well, I think in the old, I'm old enough that I remember when the diagnostic paradigm involved ventilation, perfusion, lung scanning as your first diagnostic maneuver. And one of the advantages of that was that you couldn't see the clot, so it couldn't scare you. Clots in pulmonary embolism, unfortunately, even saddle pulmonary embolism has branching across the main branch of the pulmonary artery, has not been shown to increase mortality in hemodynamically stable patients. So if they otherwise are low risk, I would not be concerned about the degree of clot as my primary thing. We stratify based on hemodynamics, not based on size of clot.
Dr. Abushalem has a nice review for us. Go ahead.
Yes, I wanted to share these two slides here. I guess that term has been used when I search for it. It has to do with the Godzilla movie, and the size does matter. And I think Godzilla in movies is getting bigger and bigger. So yes, I mean, I think if you see a large clot, and that's why I think the term have been changed from not using large, I mean, by size, but looking at the hemodynamic as Victor mentioned. So this is one of the papers that looked at saddle pulmonary embolus. Is it as bad as it looks? Again, this is the retrospective review looking at patients in their population. About 5% of their patients had saddle pulmonary emboli of this appearance and similar, and they look at what happened to these patients over 4 years. So this retrospective evaluation showed that most of these patients, and I think, had dyspnea, which is expected. Syncope was 11%, which is always an ominous sign that is concerning if the patient may have a large clot burden. But if you look here, only 16% of these patients, 16 had transient hypotension, 8%. So basically, out of the patient that have saddle PEs, about 8% of them had truly what we call it massive pulmonary embolus by hemodynamic criteria. And the outcome of these patients wasn't too bad. Their overall in-hospital mortality was 5%. They used 11% thrombolytic retrospectively for these patients. So really, the size does not matter. Is what we mentioned, and this is one of the papers that shows that the term massive probably shouldn't, makes people feel that the clot size has to do something with the outcome. It's suggestive, but the data don't suggest that. So some people, and I'm sure each one of you have seen patients getting thrombolytic therapy based on the size, where patients would otherwise not need to be, or it causes unwarranted use of IVC filter. So I think in this context, I think we need to look at what's the underlying hemodynamic status. And some patients with advanced COPD cannot take a small embolus, and they become hemodynamically unstable compared to a patient who has been previously healthy and has an acute DVT with large saddle embolus from a fracture, where they can tolerate much better.
Great, and thank you, Dr. Abu Shala, for this elaboration. I want to just remind everybody that we look at the size of the pulmonary embolus in relation to vital signs. You have to look into the background hemodynamics first, background hypoxia, if I may say, as well, just trying to be more thorough and complete. Seems that Dr. Khairallah has a burning question, so go ahead.
Thank you, Talal. Interesting case. My question would be, if I send this patient home, do you recommend any follow-ups within the next 24, 48 hours, let's say virtually, about the O2 saturation, the heart rate for that patient? I would be very much concerned that this patient goes home and then he deteriorates. And the other question, how am I going to convince the ER physician to send this patient home if I don't have PERT?
Dr. Test, please.
Well, I think I don't know how you're going to convince the emergency room physician. I think that's that one I'm going to have to leave to yourself. What our policy is at Tech is that if we discharge someone with pulmonary embolism, they get a phone follow-up within 24 hours and an in-face follow-up within 48. There's no guidelines to recommend that. If you look at the PERT guidelines, the European guidelines, the American College of Chest Physicians guidelines, none of them address routine follow-up of patients with pulmonary embolism. The PERT team makes some effort at that, but it doesn't mention what to do for these people and who are considered low-risk pulmonary embolism.
Dr. Abu Shala, any comments on that?
I think when we talked about the site, I mean, the patient that you presented, by all means, should have, a follow-up within a few days, as I mentioned. But if it is a large clot burden, and I would favor more admitting and watching this patient, so this patient would be under observation. But for those patients that have very low risk, I think it's just a close follow-up and with the primary care physician would be what I would recommend. If that's not possible, then that might be an indication to keep the patient in the hospital. If you feel like this patient lives in a small village and doesn't have good access to healthcare.
Great. So we, I like the approach that Dr. Testa and Dr. Abu Shala have included here, and that reflects the experience behind and the history behind management of pulmonary embolism. As Dr. Test mentioned earlier, I would reassure the patient actually that as long as you take your anticoagulant, any form of blood thinner is being administered, you have a low risk PE within the next 12 hours after initiation of anticoagulation with the right dose and making sure you have access to it, failure has not been reported. So he should be doing okay. Follow-up is always great, especially with such a disease, because propagation can become really a risk for certain instances. Maybe this is why it is helpful to look at the scoring systems. The simplified pulmonary embolism severity index is one of the ways to illustrate that the patient will remain stable throughout the period of observation while investigations are being carried over in the emergency department for confirming a diagnosis of PE, as it was a high possibility in this case. So what happened for this patient is basically he was discharged home with the prescription of anticoagulation. This has to have a follow-up visit within 2 weeks because of medical insurance problems in the United States. Apixaban and rivaroxaban are still prescribed under the trade forms. I don't think we have generic forms yet. There is usually a copay waiver for 1 month of having apixaban and rivaroxaban, but then insurance might become an issue. So making sure that we have issues and thoughts of continuation and continuing the anticoagulant. Dr. Al-Awadi is a dear friend and another mentor of mine who is a pulmonary medicine, infectious disease and critical care US trained physician. He was at King Faisal, but now he abandoned us and went back to UAE. I think he has a thought to comment on, so please go ahead. Yes, we can.
I have just 3 quick comments actually. I just the statement. In pulmonary embolism, the size does not matter. If the patient who is diabetic, so the size does not matter. In this specific case, and the patient had history of hypertension, when he came in, his blood pressure was normal. You have to also say, I can check for a normal blood pressure with somebody who is known to have hypertension. The case in so maybe also if somebody considered admit to ISIS in that perspective, it's reasonable. Of course, I agree with answer number 2. But thing I want to send the message that these cases in real life comes to ER told the ICU or told the medicine, say wait for the medicine to come start and you have to start anticoagulation while you want to wait for the ICC, you can see start anticoagulation. That's a key important message. Thank you.
Well, thank you, Dr. Al-Awadi. I think what you are trying to point at will be elaborated in the next cases. So he was talking about baseline blood pressure, oxygen saturation, people who have relative drop in their blood pressure from their baseline. All that will be looked at and considered as we discuss the other patients. But this patient remained vitally stable. Blood pressure is the same as baseline. Heart rate remained the same, was not hypoxic. We are trying to point out that CT scan may look horrible, but we are managing the patient, not the image. So this is quite important. And in fact, as long as he remains stable, I like about the ACCP guidelines that Dr. Test elaborated on, that we could safely discharge the patient and continue to follow as outpatient. There is no need to admit the patient to the hospital for that reason. Now, let me go to case 2 just for the sake of time, because I think it will take more discussion and thoughts from everybody. And I see some of the questions that Grace will kindly moderate by the end of our session through the Q&A session. So just to illustrate for the audience this point. The second case is a 48-year-old female who has a history of obstructive sleep apnea, had recent laparoscopic cholecystectomy about 2 weeks prior to her clinical presentation with sudden onset of shortness of breath and chest tightness. Her blood pressure on presentation was 118/59. Interestingly enough, her heart rate was 110 following, I promise I didn't look at Nabil's presentation when I did these slides, saturation of 92% on room air. She was actually in mild distress and was using her accessory muscle. So she was tachypnic and she had a clear chest exam. She had tachycardia with regular rate and rhythm, a remarkable abdominal exam, had swollen right lower extremity with a tenderness to palpation. Her lactic acid on presentation was 3. The upper limit of normal at our institution is 1.9. I think it is the same everywhere. CBC within normal limits. Her chemistry was unremarkable. She had significant elevation of pro-BNP. The upper limit of normal for us is about 350. So she had 1200. And her high sensitivity troponin I was also positive, which means she had 2 tests and the delta was positive. As we like to look at images and learn from images in relation to the clinical presentation, this is her CT scan of the chest. And again, as you see, the thoracic arch splits into the ascending and descending aorta. You start looking at the main pulmonary artery arising with branches. Usually the left one appears first, and then the right, and you can see that she has significant clots with a saddle embolus that was mentioned by Dr. Abu Shala in his quick review for the first case. Most of the clots are acute. And then when you look down to the cut of the heart that shows the RV to LV ratio, we have significant dilation of the right ventricle. So you may not need an echocardiogram to illustrate that the right ventricle is significantly enlarged compared to the left ventricle here. So if we want to look at an RV to LV ratio, it's probably 2:1. And then as we go down, we see the remaining unremarkable findings of the lung. So this is, again, the CT scan. And if you believe in looking at the ascending aorta to the main pulmonary artery ratio, the main PA here is also enlarged. And as we go down, you see the significant enlargement of the right ventricle. This is the echocardiogram, if you believe in looking at echoes, and more to elaborate on the clinical presentation and findings. So you can see that the RV is significantly enlarged. The left ventricle is pancaked, pushed by the septum to the left side. The left atrium is also squished, which is one of the signs in acute pulmonary embolism for impending shock. The right atrium is significantly dilated. Reminding everybody that the vital signs, her blood pressure was 110/59, and her heart rate was 110. She was relatively hypoxic to her baseline, but not needing oxygen. And these are the findings on CT angiogram, the echocardiogram. High sensitivity troponin was positive and pro-BNP was in the 4-digit range. So what do you want to do for this patient? And this is the time where we have your input on a patient that has a different clinical presentation. We want to admit the patient to a regular hospital bed and start anticoagulation. Admit the patient to the ICU and start anticoagulation, and no other interventions are warranted unless the patient deteriorates. Or we admit the patient to the ICU, we start anticoagulation, and discuss catheter-directed interventions. Perhaps admit the patient to the ICU, anticoagulate, and think about systemic thrombolysis of different doses. Or maybe we ask thoracic surgery to do surgical embolectomy if this is available at your institution. So out of these options, what would you choose? I'm going to allow a couple of minutes just to go over interventions and see what we should do for this patient. All right. Shall we look at the answers? Interesting. So most of us want to observe the patient in the intensive care unit. Most of us in the intensive care unit want to push for a catheter-directed intervention. Some of us think that maybe we need to observe and just start anticoagulation. Few think maybe systemic thrombolysis are indicated. Let me hear thoughts from our experts. Let me start with Dr. Abu Shada.
Well, I'm looking at these answers here. First, I mean, I think the guidelines will choose number 2, admit to ICU, start anticoagulation, and observe if the patient deteriorate. That's what the 2 guidelines, I think the European Society of Cardiology and the ACCP. Now, I personally would choose number 3, which is I would discuss catheter-directed thrombolysis. I think we have preliminary data. I think if we had time, I'll share with you some meta-analysis of the number of CDT trials in the past 10 years since it was started, that it shows that it has a good outcome. It is very safe, and it's probably cost-effective because if you do it, you probably can get the patients. I've done quite a few cases similar to this where we got the patient out of the ICU then in 24 hours, and then they were discharged home in 2 days after getting this low dose of continuous infusion. I don't think that there's any variation, and I mean there's quite a few variation in the dosage, but that would be the one I would favor. I would certainly not give systemic thrombolytic to this patient. I think there's no way to justify the patient ended up with an intracranial bleed to say whether the patient was not truly in shock, even though lactic acid is elevated. Certainly I would not do surgical embolectomy at this point.
Dr. Test.
Well, then this is the kind of real world thorny question that comes up, right? Again, guidelines, no matter how well written and how up to date, leave us in areas that are unclear. The real question is does this patient have shock? Right? They don't have hypotension, but they have tachycardia. So her shock index, which is heart rate divided by blood pressure, is abnormally high, suggesting that shock is present. She has evidence of end organ hypoperfusion. So I certainly think that starting anticoagulants is the first step. Admitting to the ICU, I think, is a better choice than admitting to the hospital ward. I think that here where we get into the question is the definition: is the patient in shock or is the patient not? And if you determine that the patient is not in shock based on your physical exam, not just on some hard and fast rules, you have some we can use, but in the general picture, you still have to make a decision. If you feel like the patient's in shock, then you have to pursue more aggressive therapy. This patient's 2 weeks out from cholecystectomy, so it has contraindications to systemic thrombolysis. And so then you're left with some, if you believe the patient's in shock, with pursuing a catheter-directed therapy. And depending on where you are, that would vary. Now, I would suggest, though, that if the patient weren't in shock and you were treating this as submassive PE, high-risk submassive PE, if the cholecystectomy question wasn't in play, the guidelines suggest that systemic thrombolysis is the way to go. And actually, catheter-directed thrombolysis is not new. It's been studied for over 50 years. The first trial of thrombolysis in PE was the UPET trial, urokinase and pulmonary embolism trial, and it was a catheter-directed trial. So I think this case, catheter-directed treatment, either with very low dose thrombolysis, like using an ECOS catheter or a embolectomy catheter, is probably your best choice in the patient after having cholecystectomy. Surgical intervention is an option that was studied well by Dr. Goldhaber many years ago in patients with submassive PE, and they had very good outcomes. Their biggest risk of death after surgery was not hemodynamic collapse from that operation, but from recurrent VTE causing recurrent pulmonary embolism. So if you do that, then you have to rapidly pursue anticoagulation, or at least temporarily an IVC filter.
Thank you. I think that this case is great in elaborating that I'm near shock. Probably I have shock by shock index criteria when, as Dr. Test have elaborated here. I wanted to redirect the question to you both on how about if we do not have catheter-directed interventions? Some of what the attendees here may be in parts of the world where catheter-directed interventions may not exist. Then what should we do for such a patient? Dr. Test.
Well, I think in that circumstance, if the patient, in this patient, if you do not have catheter-directed therapy and you don't have, of course, assuming that you don't have catheter-directed therapy, you probably don't have extensive vascular surgery support either. I would say anticoagulation, and then if the patient develops progression, then you have to choose a systemic thrombolysis, or you have to pursue transfer to another facility before you get to that point.
What dose of systemic thrombolysis, Victor?
Well, that's all guesswork, isn't it? I mean, the MOPET trial would suggest that 50 milligrams of TPA is safe, although they were excluding patients with recent surgery. The ultra low dose TPA, I don't think there's really enough data to support that, although you can always give more, right? If you give a low dose, you can always give more if you feel like you didn't give enough at the first time. So I would say you're probably going to go with a moderate dose of TPA with hemodynamic collapse in that circumstance. If they are in full-blown, impending cardiac arrest, then you give what you give, and then you have to deal with the bleeding aspects of it later.
Dr. Abu-Shalem?
I mean, I certainly fully agree with Victor about these decisions. The things that I routinely do in those patients is really patients and family. I talk to them about the risk and benefit. I think since that if I'm going to use a thrombolytic therapy, if there's no availability for a catheter direction, and I think first I would favor a lower dose than the full dose, but I would explain to them the risk of bleeding. And a lot of time the patient can help you in that decision. Some patient would say, absolutely not. I will, stay the course and not use thrombolytic. And then I would, feel comfortable that if this is a patient's, family, as long as they get informed, decision and information properly about the risk and benefit of those two things. So I like to have a share from their end, given that we're using a medication that can cause a major complication.
Yeah, I think that is a tremendously important point, and I wish I'd have made it myself. When I see people, even without the complication of recent surgery and decision making, I go through all our options. I talk about what the relative benefits and risks are, because I think shared decision-making in pulmonary embolism is very important, not just across healthcare professionals, but particularly with patients and families, so they understand the gravity of the circumstance and what we're doing to help them. And I think that was a wonderful point.
Great. I used to have a slide from my dear mentor and friend, Vic Tapson, about 11 different catheters that we have around for PE, and which one of them you want to use and which one would you recommend. Victor, I know you are probably in favor of not considering them from prior discussions about different patients, but say, as you kindly mentioned here, this patient seems to be on the edge and maybe we need to think about something. Which catheter would you consider if you don't want to give any TPA?
Yeah, if I don't want to give any TPA, you really almost just have to take the catheter, so the embolectomy catheter that your facility has. For example, in our facility, our embolectomy catheter is the Inari catheter. That being said, it's in trials now to evaluate this very question, for comparing it to other catheters and comparing it to anticoagulation. So it's not yet been proven, even though, boy, the pictures you see from it are really impressive.
Right.
And I think you have to deal with the devices you have at hand. Even and at our medical center, we don't have an endless number of choices regarding what we do.
Great. Now, before I move to the third case, one last question to you both. What are the contraindications to catheter-directed interventions? When would you not consider using a catheter for a high-risk case that you really want to do something more than just anticoagulation? Dr. Abu Shala?
Not an easy question, Talal, but I think, a patient, for example, and if you're excluding the option of thrombectomy, catheter-directed thrombectomy, but I think those patients that I feel absolutely cannot get thrombolytics because of the very high risk of bleeding, particularly like intracranial bleeding and like recent neurosurgery, then these patients would, know if there's a catheter option for suction or embolectomy, great. If not, these are patients I would push for the surgeons to do surgical embolectomy.
Victor?
No, I think that's a very balanced way to look at this. I will freely admit that I am far more conservative in the management of submassive pulmonary embolism than most of the current thinking, because as yet we haven't proven that it improves mortality. But in those patients, I think the group of people that I'm really uncomfortable with doing catheter-directed therapy are the patients who are the most precarious. Systemic thrombolysis, we know, has a fairly predictable response in most patients. And if they don't have a contraindication of systemic thrombolysis and their right ventricle is severely under stress and their hemodynamics are really compromised, I don't typically advocate using a catheter-directed therapy in that circumstance. I think you go with the therapy you can get done the fastest and it has the longest track record of effectiveness.
Great. Thank you very much. Just for the sake of time, what happened to this patient was really an ICU admission and discussion of further interventions, and everybody felt comfortable proceeding with the FlowTriever device, catheter-directed thrombectomy. It's a suction catheter that has fenestrated discs, and it allows going in, inflation of the discs beyond the clots, and then you suction everything out back. It has glorious pictures, as Dr. Test mentions, and usually interventional radiologists or cardiologists like to post these pictures in their progress notes just to see the value of doing this. It's probably the best that reduces the hospitalization or the ICU admission per the FLASH registry data so far that we see. Dr. Al-Awadi, you may want to unmute yourself first.
Yes, thank you very much, actually. And there's always a bias because if you're in a center who are really have a program of intervention radiologist who does the echoes at that, you'll be biased to take your patient for discussion or early intervention. That's another factors. It's different in real life when you don't work intervention center or your intervention center are really not experienced in doing this. They do 1 or 2 cases per year. So that will also affect your decision.
Certainly. So center experience is extremely helpful to avoid complications and things that may arise. Dr. Jamil.
I have actually a question that's always get asked about it, and there is based on a previous study done, I think, in the beginning of 2000 about DVT. With this case presentation, would you do a Doppler lower extremity? Does it affect your decision for the management? Especially the study was published at the beginning of 2000. They mentioned about if it's positive DVT, that will increase mortality comparing with people with negative Doppler lower extremity. What's your experience with this? Would you do those Doppler as part of your testing, or this is something you would not consider?
Great question, Dr. Jamil. The best data I know is derived from 3 registries. It's called the Prospect trial, where they looked at 848 patients with normotensive clinical presentation with PE. And they looked at who are out of these 848 patients, people who had clinical deterioration from pulmonary embolism. One of the main 4 factors was finding of DVT on lower extremities. Does that mean we are going to put a filter in everybody who has a clinical presentation with DVT and PE? The answer was not, as was answered in another study in JAMA that was published in JAMA in April of 2015, where the outcomes of placing temporary IVC filters did not really help patients as long as they get anticoagulation and they are able to receive the right dose of anticoagulation. So for risk stratification at our institution at Duke, we order lower extremity ultrasound for assessment of DVT, even if we know there is a diagnosis of PE, just to risk stratify the patient before discharging them home. That is important to risk stratify the clinical presentation once their simplified PE severity index is positive. If they have a normal SPESI, we don't do ultrasound of the lower extremity. We just rely on stability of SPESI for the period of observation during their emergency room stay, and then they could get anticoagulation and go home. Dr. Test, any thoughts on assessment of lower extremities?
Well, I think, yeah, I mean, again, I take a similar approach to what you take. If the patient has symptomatic DVT, I always look. If they are lower risk, I don't. Again, the most important predictor of outcome in VTE is a prompt anticoagulation within 6 hours. In the patient with submassive PE or intermediate high risk PE, there actually is some data suggesting that that placing an IVC filter in those patients can have a benefit to them, but it has to be done in the first 48 hours. After 48 hours, that improvement goes away. I don't routinely place that. Again, I look at the individual patient. If the patient has a large iliofemoral DVT, then I might consider placement of an IVC filter in that circumstance. But I would say that the guidelines suggest that is not currently is not the way to go. That you should just anticoagulate and treat symptomatically.
But if I can just add that we have a lot of listeners with this webinar. They don't have access to a lot intervention or even IVC filter. Would it change your management? Would it make you more aware, cautious, like especially in case number 1, if it's positive DVT, you still send him home and not consider? Because IVC is not available, they might not have this. They would change your management in general.
Yeah. It's a great point, because it also illustrates why the guidelines can't always tell us what to do, right? And an answer is, I don't routinely do that in patients with low risk DVT that I see is in the emergency department. Again, if they're symptomatic, I always do. And then from that, we decide based on that individual how we're gonna proceed. At our facility, which we don't have access to around the clock diagnostic venous ultrasonography. So by the time that happens, the patient's usually been in observation for a significant period of time anyway, and so that gives me that luxury as well. But I think the guidelines can't help you on these decision making. You have to kind of base each individual decision on your own experience. And if the patient has a symptomatic DVT on the right, yes, you'd be perfectly justified in saying this is not a simple, uncomplicated DVTP, and I'm going to admit this patient and take care of them aggressively with anticoagulation so that I can keep them under closer observation. Absolutely, that would be appropriate.
Dr. Abushala, any comments, or should I move to the third case?
You can move to the third case. Yeah.
All right. Just for the sake of time, this is an interesting patient that I actually took care of 3 weeks ago. So right on target. 72-year-old male, had history of COPD, coronary artery disease. He's on home oxygen at 4 liters at rest. He presented to the outside hospital ED and then transferred to our facility for worsening shortness of breath and chest tightness for 4 days duration. He also had cough and wheeze, as well, was thought initially as a COPD exacerbation, but given the topic we are presenting, he actually had pulmonary embolism. So his blood pressure on presentation was stable, heart rate of 78. His saturation was 82% on room air. That improved to 91% on high flow nasal cannula. He was on conventional high flow nasal cannula. And then on arrival to our ED, he was transitioned to heated, humidified high flow nasal cannula, or what we call OptiFlow. He had distant breath sounds, reduced breath sounds on the right, actually more than the left. Normal cardiovascular exam, unremarkable abdominal exam. His lactate was 2, CBC was within normal limits, and chemistry panel was unremarkable. So he had normal creatinine and normal liver function. His pro-BNP was elevated at 832. His high sensitivity troponin was borderline positive. So looking at his CT scan of the chest, and I want to show you guys what he had. So this is his CT. And again, as we reach the thoracic arch, we try to go down. You see the main pulmonary artery trunk, and it's actually big compared to the ascending aorta. And then as we go down, let me just go back a little bit. You see the main pulmonary artery on the left, right has this filling defect that seems to be layered on the right main pulmonary artery. So it's right here. This is where the filling defect is, and it's thought to be pulmonary embolus. Then as we go down, you see more in the right lower lobe here, and nothing much on the left side, but the clot remains, and he has the CT scan finding. If we go back just to focus on the right ventricular to left ventricular ratio, so we value looking at that now compared to many years ago, you see that the right ventricle is severely enlarged compared to the left ventricle, and he has enlargement of the right atrium, and the left atrium looks smaller in size. So with that in mind, and this clinical presentation, what do you want to do next for this patient is an echocardiogram, just to be sure, and this is his echo. See, the left atrium is also small, right atrium is enlarged. This is a nice example, but probably less severe than the previous one, where you see the apex is predominated by the right ventricle, but the left ventricle is not as squished and less mobile. And he has still significant dilation of the right ventricle, since it is more than the endoventricular size of the left ventricle. So enlarged RV, apex predominated by the right ventricle, enlarged right atrium, left atrium is small, and the clot that we have observed. So what do you want to do for this patient? Start anticoagulation, give him systemic thrombolysis, consult surgeons, maybe think about a catheter-directed intervention, or consider having a group discussion about what to do next. Allow 15 more seconds just for the sake of time, and then we'll look at the results, hear on thoughts from our experts, and then we'll move. Shall we look at the results, please? All right. 41% want to anticoagulate only. Administer systemic thrombolysis was only 2 out of the 66 people who voted. Surgeons were not favored. Also, call interventional cardiology about 24%. Consider having a group discussion about 19%. Dr. Abu Shala, your thoughts?
Right. So this is, again, one of those borderline cases that I don't think there's a right or wrong answer. I personally would do a group discussion. I think it's you know, if you are privileged to work in a hospital, they have a PERT team, that's ideal. If not, then I think it's, you know, discussing this with cardiology, or interventional radiology and look at the options. This is a patient probably has chronic pulmonary hypertension, as you described, have chronic COPD. So I'd like to know more about the severity of his chronic lung disease. As we said before, even though size doesn't matter, this doesn't look like a large clot, but it may be significant for someone with chronic lung disease and significant COPD or emphysema, where we'd take a more impact. So my feeling is that we need to look at the whole picture and try to look at options. And again, depends whether we have, you know, if we're going to use thrombolytics, I would, you know, look at the again other factors in his case and discussing it in a group discussion.
Dr. Test?
Yeah, this is a really great case, and it's really it's you know, it presents a lot of difficulty. I agree that the information, the size of the pulmonary artery, the degree of tricuspid regurgitation, the relative amount of clot burden, all suggest pre-existing, you know, pulmonary vascular disease probably from the underlying emphysema. I think it also, you know, it highlights again the difficulty we have using just blood pressure and pulse to guide us regarding shock. The patient's not hemodynamically in shock, but they have profound hypoxemia. And that's one of the things we have to take in consideration when we make judgment about how to treat these folks. I do think that a group discussion is an important way to go here. You know, at my current place, I am essentially the PERT team. You know, so I would bring in the people that I thought I needed to help me make that decision. I don't think this patient's ever going to be a candidate for a cardiothoracic surgery. Systemic thrombolysis, I think, you know, it might be a reasonable choice. There's not a huge clot burden there, but when you look at that CT, it gives the impression that that the patient might have a pulmonary infarction, because the part of the lung that was most involved with the PE and with the highest degree of obstruction was very abnormal, even on the mediastinal windows. I think it brings in how you have to take in every facet of the patient. I think you could make, you know, with a group discussion, you might well decide just to anticoagulate this patient, and that's where I would start. Because while I'm having my group discussion, the patient and with whomever else I felt I needed to call, probably cardiology at our institution. I'm going to anticoagulate. If his hypoxemia starts to improve, then I do nothing more than anticoagulate him. If however he doesn't improve, then that rebuilds the balance of decision making towards being aggressive with catheter-directed therapy. But I do think informed discussion with the patient and the rest of the team is maybe the most appropriate response after you anticoagulate the patient.
So great thoughts, and our experts here thought about talking about group discussion. What do we mean by group discussion is always a difficult thing, right? So this is the concept beyond what we call a PE response team. It's a multidisciplinary discussion that is usually raising for an unclear case that you don't know what to do, or you probably think you know what to do, but you want to plan the next step after that. I left the link here for all of you. It's a really nice consortium that was generated and built by 3 physicians out of their pocket, but now it's a non-for-profit organization that looks into and shares basically what we should do for management of pulmonary embolism patients. So PERT equals easy access to all physicians who are needed to think with us about a particular case. It basically means also rapid evaluation. You're getting a multidisciplinary consult between interventional cardiology, radiology, thoracic surgery, especially if you need ECMO and you have access to that at your institution. Radiology have valued input, and I'm going to illustrate why chest radiologists were of a great help for this particular case for us. And it gives you also an expert evaluation for people who look at PE cases frequently. The key for setting up a multidisciplinary discussion rises from motivation. It is also important, and we learned that here at Duke, and Victor Test was of a great help for us to have that generated and ongoing when he was with us here. It generates lots of thought processes. We think that an algorithm or a flow chart for management of PE will be helpful. So you really don't get called about any case, because it can result in consultation fatigue and tiredness. And you don't want that. You want really a tricky patient that you don't know what to do with is the patient who should have a PE response team discussion. It's a great learning experience for teaching availabilities and teaching in general for all patients, for all physicians and providers. It utilizes already available specialties, and it's easy to set up if you have a common pager that you page and then it directs to all other specialties. You could do that through the operator of your institution. You could do it through a common page. So we have a functional pager here at Duke that is linked to 6 different functional pagers of services. So whoever is on call will get this call in addition to the primary team. And the system allows you to add more services. So say a patient who had PE and an intracranial tumor. So you want neurosurgeons to be included as well. You could also add the neurosurgeon on call to this discussion, so it becomes readily helpful and available. PERT members typically are those services. You need a pulmonologist, a cardiologist, probably to balance things out. And Dr. Abushala was mentioning guidelines in management of PE. Cardiologists usually tend to do more aggressive interventions. In fact, the latest recommendations by the American Heart Association is to do the standard of care of any submassive PE to them is catheter-directed intervention, which is not necessarily true or the case for all patients with submassive PE. While ACCP guidelines recommend observation in an ICU and then consider rescue therapy or catheter interventions on individualized basis. And if you want to look at the Annals of Internal Medicine guidelines, they have different approach. American Society of Hematology guidelines, they also have different approach. And here rises the importance of carrying a PE response team discussion about services as they may arise. Most of the time, you really have a discussion between the ICU team, pulmonologists, cardiologists may weigh in just for realizing that we need an answer and maybe look at the echocardiograms as well. Number of consultations can be bothersome, and therefore it's important to have a flow chart for management. And what we found at our institution and also at MGH, that we ended up doing less thrombolysis compared to before initiation of a PERT team. We have better monitoring for high-risk patients by anticipation, and also better utilization of resources. So for example, in our institution, ultrasound-assisted thrombolysis, which is favored for rather distal clots if you want to do a catheter intervention, is done better by our cardiologists, while the suction thrombectomy is done better by our interventional radiologists. So utilization of resources is quite helpful. And what happened for this particular patient, if you want to look at things, the chest radiologist was suggesting, let's look at the lung window together for this particular patient. And here we go. I think it gives you a lot of information. He has destroyed lung, and particularly the right side of the lung has all emphysematous, rather destroyed lung. And look at the the right lower lobe as it arises. You see this huge emphysematous bully with what looks like a hydropneumothorax, but it was all fluid filling a large bullous emphysema on his right side. And the left side is not any better either. Now, Nabil and Victor look at patients and CT scans all the time, and they could tell that there is probably an element of chronicity by listening to the patient, but we do not have experts all the time. I think it is helpful to look at all what you have before you make a decision. So based on this CT scan and the lung window finding of this patient, it was thought that he probably had a thrombus in situ that developed, especially that when we looked at the lower extremity with an ultrasound, he didn't have any clot in the pelvis or in his lower extremity. So he just had poor flow to the right lower lobe and ended up having some sort of stagnation and clot that accumulated there, maybe leading to an exacerbation of his underlying COPD. And that's why he was more of hypoxic rather than hemodynamically unstable for the clinical presentation of his PE. So what we ended up doing for this patient was really more just considering having a group discussion, and we started anticoagulation. And within 12 hours, he actually normalized his oxygen saturation back to his baseline as the clots were more organized and stayed in place, and he really needed nothing else to be done. Any final comments from our experts before we go to questions? Dr. Abu Shalab.
Oh. No, I think that's the alarming part is really seeing how bad the lung disease in these patients, and I think that would make everyone, decide that is he really sick because of that finding, or is it because of his severe lung disease? So I think it's you have to always look at the big picture.
Dr. Test.
Well, again, I think you illustrated everything that I would say, and I just want to say again, anticoagulation works. Okay, it works for the overwhelming majority of people. It's been time proven. And if you look at the Cleveland Clinic data on their PERT team, the most important thing they showed decreased mortality with their PERT team. But the biggest difference from the pre-PERT to the post-PERT era was that they achieved a higher rate of anticoagulation within 6 hours. It was substantially different. And so that to me is always the most important thing I can do for every one of these patients, as well as making a good, solid, fact-based and evidence-based decision.
All right, so we exceeded our time, so I'm gonna try to have few questions. I'm sorry, Dr. Al-Awadi, I wanna try to have few questions from the attendees. So Grace, please go ahead.
I'll ask some of the questions from the chat just to help for the sake of time. So firstly, what about streptokinase in PE?
Streptokinase in PE. So I thought I would never hear that, but it is considered, right? So the very first trial in massive PE I know of was in 1995, where they randomized patients with massive PE to get streptokinase versus just anticoagulation. And all those with obstructive shock died if they did not get streptokinase. So it works. We know it works, but you want to be careful about the anaphylactoid reaction that might happen from streptokinase compared to alteplase. Dr. Abu Shala and Dr. Test, any thoughts on this?
I mean, I've seen severe fever from streptokinase, but I think we've used it once when there was no other alternative. But yeah, I think in these day and age, I think using the other medications available for thrombolytics is much better.
Great.
The next question is, what about the role of thrombolytics if a patient suddenly collapses and arrests, and how can we give it?
So CPR or PA arrest from PE, and you don't have IV access, I suppose. What should we do? Nabil?
Well, I think you establish. I mean, it's in any patient you have to establish an IV, and yeah, I think we've given TPA in this situation where we suspected the patient had PE or known to do that. I think in this day and age, if you're working in a tertiary hospital where ECMO is available, that would be the best choice. Is those patients who arrest from a PE where this could save their life.
Dr. Test?
Well, yeah, I think absolutely, and the standard for TPA, the standard dosing regimen is 10 milligrams IV over 10 minutes. In the setting of cardiovascular collapse, of course, you don't have to follow those rules. You can give the medication faster, but certainly I would lead with a bolus of tissue plasminogen activator, and then you have to have IV access to do that. Of course, if you don't have IV access, you're not going to have success in this endeavor. Could you do it through an interosseous line? Yeah, probably. I've never done that, but I suspect you could.
I did.
See, I think you do what you have to do. And the patient with persistent cardiovascular collapse, then ECMO, absolutely, if that's an option for you, is appropriate. Unfortunately, not everybody's really blessed with a high quality rapid response shock team to let you do that, though.
Great. Next question, Grace.
Great, thank you. A few of the questions have already been answered, so thank you. One of them was, at your facility, is it interventional radiologist or interventional cardiologist? But I think you described that it changes depending on the case and their expertise. Going through some of the other questions, is there any reason to limit mobilization in stable patients with multiple segmental emboli and DVT who are discharged home in full anticoagulation?
Nabil?
No, I can't think of a reason that you have to limit the mobility of the patient in those contexts. I mean, I always like to make sure these patients did not have an extensive iliofemoral DVT if they're symptomatic, but yeah.
Great. Next question. I think Dr. Test would probably agree on this.
What anticoagulation medicine do you prefer to use in ICU?
Victor?
Well, I don't think it matters too much as long as you achieve therapeutic anticoagulation. In our institution, if it's not, a lot of my colleagues prefer unfractionated IV heparin. But the problem with that is you are not assured of achieving your levels. I prefer low molecular weight heparins. It doesn't matter to me which one it is. I vastly prefer that because they're far more predictable and you can achieve a therapeutic dose within a very rapid period of time. A lot of times the argument against that is, well, what happens if you have to take them to a procedure? Well, I would just suggest to you that they still need to be anticoagulated when they go to that procedure. These are venous procedures in this circumstance. And so the risk of, and remember our cardiology colleagues take people to the cath lab all the time through arterial access in patients who are fully anticoagulated and receiving dual antiplatelet therapy to prevent additional progression of their myocardial infarction. So I have no compunction about putting them on low molecular weight heparin.
Great, thank you. I'm not sure Dr. Abushala has anything to add, but he's
No,
nodding.
I agree. I fully agree with that. Yes.
Perfect. Lots of questions coming through. I'm just trying to vet them. I think quite a lot of the questions are talking about catheter-directed therapy, but you have covered that since.
So analyzing through the questions, Grace, I'm trying to cover things that were uncovered.
Yeah.
So Dr. Zachary was asking, what made us think about PE in the third case? Well, I'm sure you know that a lot of patients with underlying emphysema and chronic bronchitis or severe COPD, it is important to think about pulmonary embolism as an exacerbating factor. So we miss a lot of PEs in COPD patients when they present with what we think is a COPD exacerbation. So it's important to keep this in the back of your mind whenever they have objective deterioration. If they have symptomatic worsening only, you may start empirically managing them. But if they don't improve, keep PE at the back of your mind. I think that's probably the only question that...
I think there's a final question, perhaps. If you've treated with TPA and there's still not adequate improvement, would you then consider thrombectomy?
Full dose alteplase and they don't recover, then what to do next? Victor, what do you think?
Well, I think that depends a lot on the interpretation of the original scan, right? I mean, how much of this is acute and how much of it's chronic? The mortality of surgical embolectomy in this subset of people with refractory shock, and particularly refractory shock on ECMO, is going to be extraordinarily high. When you say, well, the mortality is going to be extraordinarily high regardless, and I understand that point, but I think you've already done what you can do. You're not, in this circumstance, rescue embolectomy is very unlikely to be beneficial. The question is, do they have chronic thromboembolism, in which case then you might have a role for endarterectomy in addition to embolectomy as well. Unfortunately, sometimes we misdiagnose chronic clot for acute clot, and that would be the circumstance where you would not be able to necessarily see an effect with thrombolysis.
Nabil?
Perfect. Oh,
No,
sorry.
I think, I mean, in this patients, that if the patient have acute thrombotic fresh clots, they're certainly failing thrombolytic therapy, the suction device, whatever is available, would be a great option. So some form of thrombectomy, but I would favor, and I think now it's becoming definitely a lot more available to do that through interventional radiology, to do the interventional thrombectomy.
Great. Thank you for answering the questions. We're going to finish up tonight. Thank you for everyone who's stayed during the whole webinar. It's been fantastic and very informative. Thank you so much to Dr. Dahan for leading the discussion, and also especially to our expert panelists, Dr. Tess, Dr. Abushala. We've also got Dr. Alwadi and Dr. Jamil, who've been able to contribute as well tonight, as well as Dr. Kerala, who's with us most weeks. So we're just so grateful for the experience that you've been able to share. So I think we've all learned a lot. I know I have especially. Just to finish, for those of you who maybe aren't familiar, ICU Reach is a platform that you can find online. You can type it into your search engine, and on there you will find lots of resources. There's also options to register and to sign up. Other than that, I'm going to announce our next webinar. It will be on the use of nebulized antibiotics in the treatment of Acinetobacter, and that will be by Dr. Alwadi. The date will be announced soon. It's not yet confirmed, but it will be announced on ICU Reach, which I've discussed. So if you're a member, you'll also receive an email letting you know the date of this. Otherwise, that's everything for tonight. Thank you for your questions and your participation in the polls, and we look forward to welcoming you again.